Good morning, everybody. Thank you very much for the organizer to have this symposium. I think it is an exceptionally important question. And considering that more than 55 years ago, Martin Luther King said that he had a dream, and it is interesting to be here 55 years ago or later in a different country and think that we still need to dream about the time when people who need this life-saving living donor transplant, all of the people who need that will have equal access or equitable access to that. And so I will briefly talk about this issue. It's very, very complex. Many of our research is shown on the posters around. Please look at the research and talk to the people who present that. And we'll hope that at the end we have a better understanding, at least about how to start the work and how to start to reach this dream of equitable access to living donor transplant. In this talk, I will briefly mention the different dimensions of health inequity, also touch upon what we know about inequitable access to living donor transplant internationally and in Canada, and then we'll just show a snapshot about the work that we start to do and hopefully we'll complete over the next coming years with many of the partners who are here in the audience. So when we talk about health equity, of course, there are many other dimensions, not only ethnicity or race or culture. Inequity can be seen in disease occurrence or disease frequency. Different groups have a different risk to have certain conditions. For example, South Asians have a higher risk to have diabetes, even if they're lean. And if you have diabetes, you have a higher risk of kidney disease, of course. Access to care, so once you have a condition and you need to access care, is not evenly distributed in many societies, including ours, unfortunately. And across those different categories that are listed on the left side, sex or gender, age, socioeconomic status, income, ethnicity will have a major impact, both how you can access health care, the quality of care that you receive, and as a consequence, the outcome or health outcomes, the outcome of that healthcare intervention that you receive. Just to quickly show sex disparities in transplantation, it was mentioned that about 60% of living liver donors are women. Several studies suggested that a similar situation exists in the kidney donation as well. This is a Canadian study published years ago showing that out of the people who start the donation process, women are more likely to complete and at the end donate compared to men. Age is also an important factor to consider where not everybody who could have that or who would need it will have access to living donor transplant. On this graph, you see that compared to young and quite arbitrarily defined as less than 45 years of age, young individuals, even the ones who are between 45 to 65 have substantially less chance to get a living donor transplant. And people above 65, they practically almost excluded from receiving living donor transplant, partly because they say that even if someone offered me a kidney, I would not accept it. And this is actually a recurrent theme, not only in terms of age, but also ethnicity and cultural groups may have some concerns about accepting the living donor transplant. So what do we know about inequitable access to transplant when it comes to ethnicity or race? Much of the research that looked into this is coming from the United States, where it has been repeatedly and clearly documented that compared to white individuals, here these longer bars represent white patients, both Asian, Hispanic, African American and indigenous people have a much reduced chance to have a living donor transplant and also a deceased donor transplant in general. This is true for European countries. There has been research in the Netherlands, in the UK, again indicating that South Asians, black patients have less chance to receive a transplant. And some of it, as it was mentioned earlier, might be related to religious beliefs or religious concerns. And shown here is that Muslim South Asians in the UK had more concerns about transplant than non-Muslim South Asians. In Canada, of course, when we think about healthcare and access to healthcare, Indigenous peoples need to be considered. This graph, again, first of all, it's important to emphasize that race, ethnicity, socio-economic status, geographical location obviously interact in access to healthcare. This graph or this map shows you the density where indigenous people live, and of course most of the advanced healthcare facilities are on the southern border of the country, whereas most of the indigenous peoples live in northern, more remote and rural areas. So partly as a result of that, but partly of other factors, when compared to whites, here in the orange line, indigenous people who have don't have diabetes, or indigenous people who have diabetes with the green line have much less chance to have a transplant and a liver donor transplant compared to white individuals. And this is also true for younger individuals who are relatively healthy. So that has been shown, and now there is a fairly large project in British Columbia. Dr. Landsberg and Dr. Gill are starting to work with indigenous peoples to understand and improve that situation. Several studies, even before our work, have shown that both East and South Asian Canadians have less chance to receive a living donor transplant in Canada. This study was published more than 10 years ago. The data had come from more than 20 years ago. And still, when we looked at our more recent data here in Ontario, we saw that compared to whites, again, both Black and Asian, South and East Asian patients who were received for a transplant to UHN had 50 to 70% less chance to receive a living donor transplant compared to white patients. So this is a huge disparity. When you heard that living donor transplant is the best treatment for kidney failure and liver failure, not everybody who needs that may have an access to that best treatment. And so this is an issue that we try to better understand and hopefully reduce these inequities. When it comes to why would people from different cultural groups, or why would people who are in a less privileged socioeconomic status not have access to living donor transplant when we have a universal healthcare system? There is many reasons to that. This kind of review article listed a number of reasons why people may not get access to transplant in the United States. One reason is that transplant is a very complex process. You need to decide, you need to know that you need a transplant, you need to know that you can have a transplant, and then you need to go through all the hoops for recipients, and for donors it might take a year or longer to get to the stage where they are cleared. And so both age, sex, and the factors I mentioned will have an impact on how easily you can get to the next step. And certainly in the United States, it was shown that people who belong to ethnocultural groups have much reduced chance to complete any of these steps along this long road to transplant. Now, this graph is even more complex, and this is where we try to understand how ethnicity, race, or culture may have an impact on health-related concerns. So even this concept of ethnicity or racial identity is very complex. Sometimes it is self-identified and you feel that you belong to a certain group. Sometimes you are being told that you belong to a certain group and you may not feel that way. And of course this might even cause tensions here. but then ethnicity and race works with multiple other factors, socioeconomic status, income. Sometimes there is a complexity between an additive effect of poverty and ethnicity. There was a question from the audience whether race or income is more important. In our research, when we adjusted for income and socioeconomic status, ethnicity still remained a very strong independent predictor of access to living donor transplant. So both are important. And of course, when you are faced with these tensions, when you are faced with overt or unconscious racism, individual or institutional racism, those experiences will define and determine how well you can trust the system, how well you can trust the institutions. They may lead to stigma, feeling stressed and distressed about this. And of course, it also affects your knowledge about these things. And frequently, you may not know what options you have, and you may not know how to approach those. So there have been some research, and it's a bit striking that it seems to be such an important issue that, well, people have less than half the chance to have a best treatment right now here. And still, we have very little research into defining what the reasons may be. And these are some of the findings that came from interviews and focus groups with individuals around deceased and living donation. These factors are mixed. There is certainly a set of religious concerns from multiple religious groups around transplantation and organ donation, but there is issues around language, knowledge about transplant. And of course, there is a very strong concern about the safety of the donor and the health of the donor. And this might be, again, differentially expressed in the different communities based on different values. So we have a complex situation. We have, I think, a very severe issue of inequitable access. What can we do about it? So first, we need to understand that equitable access to something doesn't mean it's equally available. So that's why universal healthcare, which is out there and available, it may not help everybody the same way, because certain groups or certain individuals may need more help and more support, or a different type than what it is available. So this is what we try to understand: in what way can we help patients who belong to certain groups to get equitable access. And we are trying to follow the path outlined by several research efforts in the United States and in Europe. And really the only interventions that have been shown promise in helping patients to access living donor transplant and transplant in many cases is working within the communities, working with members of the communities, working with patients and donors, as we actually start here. And this is a recurrent theme in many of the research efforts, working in a community, training peer supporters, going where the patient is, not bringing the patient necessarily to the hospital, maybe going out to the home, going out to churches or mosques, and start to talk about these issues there. Another example on a policy level, the Council of Agencies Supporting South Asians started to develop a South Asian health strategy that includes culturally appropriate care and working with researchers to increase trust and increase knowledge. Now, as I mentioned, our colleagues in British Columbia work with indigenous groups to understand the barriers and improve access to transplant. Here, we also have a collaborative effort with Dr. Landsberg and a nephrologist from British Columbia to work with Black and South Asian community organizations to improve understanding about the different burden, and also develop ways to understand health access and health outcomes in these communities, identify the barriers, and develop culturally competent education materials, and also training for professionals to better understand these issues. This is a list of organizations we have on our team, or they have us on their team, I would say, and we hope to work with them over the next few years, and this is just some of the people. Some of them are here presenting the research, and this also brings an important issue, representation, that you need to have the communities represented on your healthcare team with whom you want to work together. Thank you very much.